Robertson, Clinical Education Coordinator with LPCA. Welcome to the third and final series of our training on hypertension education. Part 3 today will be focusing on identifying proper techniques for accurate blood pressure measurement. Our presenter for this series is Mike Korsmel, fourth-year medical student at Tulane University School of Medicine. As we will attempt to stay on time during the webinar, we will again hold all questions until the end. All participants will be in listen-only mode. Please type in your question throughout the broadcast in the question box located on the webinar screen. If we run out of time, you can email your question and we will follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating. Mike, you can begin.
Okay, hello again, everybody. Again, my name is Mike Korsmel. Let's start right away. So this is part 3 of the 3-part series, proper blood pressure measurement, right tools, right technique. I'm going to kind of hurry through the beginning to make up for lost time, but the talk is split into 2 main components. The first being some quick background information that you may or may not have heard before, but we're going to get everybody up to speed. And then the latter half of the talk is really the meat and bones where we talk about the tools and techniques. So let's jump right in with some background information. To start us off, I pulled some data from 2014 UDS reports from Louisiana FQHCs, just to give us some numbers so we can see who we're dealing with, our population. So our hypertensive patients make up roughly 65,000 patients, and those patients make roughly 170,000 visits. So that's a lot of opportunities for us to get things right. And speaking of getting things right, let's talk about core measures. These are those little nitty-gritty details that really keep us on track and make sure we give the best quality care we can. So while there isn't a lot of data on hypertension core measures per se, we can use body mass index, or BMI, as a proxy. So one of the things I looked into was a core measure of, is someone's BMI charted? And if they are overweight, is follow-up documented? Just to kind of see how we're doing. So of roughly 100,000 patients that were documented to be overweight, only 56,000 patients had core measures met. So that's a success percentage of about 58.4%, which is actually lower than 2013. So we may think we're doing a great job, but the data says otherwise, and it's really, that's just room for improvement to do a better job. So why does hypertension matter? Well, hypertension chronically leads to a lot of differing disease processes like stroke, heart failure, MI, kidney disease, and morbid things like erectile dysfunction and vision loss. And so one of the issues with the general public is typically you'll hear someone say, well, mom died of a stroke or dad died of a heart attack. And I think it's less typical to hear that, well, mom died of her hypertension and dad died of his hypertension as well. So that's something we really need to stress with our patients, is that hypertension causes all of these nasty outcomes. Let's jump right into some basic definitions. Normal blood pressure is systolic 120 or lower and diastolic of 80 or lower. There's this new category called prehypertension, which is 120 to 139 over 80 to 89. So that's when we kind of want to increase frequency of screening. We'll get to that in a minute. And then high blood pressure is placed into 2 separate stages. We'll just go with 140 over 90 as being kind of our definition for hypertension. And then there are hypertensive crises. And I just want to touch on those really quickly because they're pretty important. Within a hypertensive crisis are kind of 2 subcategories, the first being hypertensive urgency. So that definition is anything greater than or equal to 180 systolic or anything greater than or equal to 110 diastolic. And the scary thing about this is hypertension is the silent killer chronically but also acutely. So this can be associated with or without symptoms like a very bad headache, shortness of breath, nosebleeds, and severe anxiety. The other subcategory under hypertensive crisis is hypertensive emergency. The definition is very similar. It's still greater than or equal to 180 systolic or greater than or equal to 110 diastolic. But the additional component here is end organ damage. What is that damage? It can be acute stroke, memory loss, MI, acute damage to kidneys, aortic dissection, pulmonary edema, and even eclampsia. And how do we identify the end organ damage? Well, that's through identifying symptoms. So chest pain, shortness of breath, back pain, for example, is classically an indicator of an acute aortic dissection. Numbness and weakness, changes in vision, and difficulty speaking. Okay, let's briefly talk about risk factors for hypertension. I think the prior talks laid those out pretty well, and my one addition here is to kind of stratify them, separate them into modifiable and non-modifiable. So beginning with non-modifiable, these are things that we cannot change. So our race or ethnicity, for example. So African Americans, hypertension tends to be very prevalent in that population. Sex plays into it. So men up until age 45 are at greater risk. Interestingly, and less well known, is that women age 65 and above are higher risk than men for hypertension. Obviously, advanced age in general, and family history plays a significant component. And so modifiable risk factors are the things that we can change, and these are the things that we need to be talking with our patients about. These are probably pretty obvious to most people, so lack of physical activity or diet. Both of those factors can lead to becoming overweight or obese, and excessive alcohol intake. And then there's what I like to call contributing factors. So stress can lead to hypertension. Clearly smoking and secondhand smoke, we know, can even lead to acute raises in blood pressure, and that's not even necessarily due to the smoke itself or the damage to the lungs, but that's just the chemical nicotine. It can be a very potent vasoconstrictor. And then sleep apnea, another one of those that the general public, I think, struggles with understanding. But the physiology is there. It's very well described, and it does lead to hypertension and further out heart failure. And then there's this last category, secondary hypertension, and these are disease states or issues that lead to hypertension as a result. And interestingly, these types of things only account for about 5 to 10% of cases. So those would be things like an adrenal gland tumor or a coarctation of the aorta, which is just simply a narrowing of the aorta, and that can happen in different places, or renal artery stenosis, which is simply a narrowing of the artery that feeds the kidney. It tricks the kidney into thinking blood pressure is low, so it tries to raise blood pressure. These are things that we can surgically correct, but unfortunately they account for a very small percentage of cases of hypertension. Moving on, let's talk about screening. So this comes from the United States Preventative Services Task Force, and they recommend beginning screening at 18 years of age, which is pretty young, but everybody, regardless of risk factors, should probably be screened at 18 years of age and up. And then they recommend, if blood pressure is normal, meaning less than or equal to 120/80, that we screen every 2 years. And then if they become abnormal or fall into that kind of category of are they or aren't they, which is pre-hypertension, 120/39/80/90, we can screen more frequently, so every year. I think clearly one of the best ways to accomplish this is to simply screen on every visit, and I think most clinics do a very good job of this. One very quick aside, the USPSTF has a great app, a mobile app for your phone that you can search for and download. It has all these recommendations that are very searchable sources, and that is the AHRQ EPSS app. That's how you search for it, and I can talk again about that at the end if people are interested. Okay, moving on. So here's our formal diagnosis. So we already talked before about the blood pressure at 140/90 or greater as being our physiologic basis, but this needs to be on 2 or more elevated readings. but then even that isn't enough. These readings need to occur over 2 or more visits, and then even that isn't enough. It needs to occur within a period of 1 or more weeks. So it's not enough just to get that one reading of 140/90. We need 2 or more elevated readings on 2 or more visits within 1 or more weeks. That is the definition. Okay, let's jump right into the meat and bones tools and technique. This is our main tool, kind of tricky to pronounce. The sphygmomanometer. Try saying that 5 times fast. So the sphygmomanometer consists of the blood pressure cuff, the bulb, which we use to add pressure into the cuff, the adjustable valve, which we use to release air and thus pressure, and then our measurement tool, which is the manometer itself. And these devices come in 3 different flavors. I think the one we're most familiar with would be the middle one, which is the aneroid. There's also digital, which can also be used in offices. They're very popular amongst patients if they're measuring their blood pressure outside. And the important things to keep in mind about aneroid and digital is they need to be recalibrated every 6 months. So that's pretty often because they are recalibrated against the standard, which is the mercury one. And the reason we measure in units of pressure of millimeters mercury is because of these old mercury measurement tools. And they were kind of phased out mostly for environmental and safety reasons. Mercury is not it's really safe to have around people. So keep that in mind. And then obviously the stethoscope is the final component. So let's talk about preparation. Patient comes in. What are the first things we're considering before we even measure? Well, we want to consider their activities, or what I call modifiers. So the first thing would be something like, have they consumed a gallon of coffee and the caffeine has acutely raised their blood pressure? Are they a smoker and they just finished a smoke outside to calm their nerves and the nicotine has acutely raised their blood pressure? Were they late for the appointment and they're running in, their blood pressure is acutely raised? Are they stressed in general? Do they suffer from the white coat effect? Something we'll discuss a little bit later. So that's really something to keep in mind, that caffeine, alcohol, sources of nicotine really need to be avoided at a minimum of 30 minutes prior to measurement. This is important. Next, position. I think we're all somewhat familiar with this, but a good reminder. So we want to start seated. Seated is the best, the gold standard. Feet supported firmly, flat on the ground. Legs need to be uncrossed. The arm should be bare to the shoulder, and that's more for cuff fit. And for the healthcare provider, it's nice to make sure the manometer is already at eye level. So if you're lucky enough to have one mounted to the wall, it's pretty easy. The arm should be flexed, and it should be supported on a table. And that elbow really needs to be at the level of the heart, because when we change the level, we'll artificially change the pressure. Okay, moving on to something very important, which is cuff fit. We need to be using the right cuff every single time because this changes pressure as well. So many cuffs, as you're probably already aware, have a nice shortcut to assess fit, and that is the index line and the range line. So take a look at the picture in the lower right-hand corner of your screen. There's text in yellow. It says index line. So that's typically at the edge of the bladder, and what that does is when you wrap it around the patient's arm, it should line up and fall within the range line, which in both pictures is the arrow kind of running in 90 degrees to the index line. So if it falls within that range, the fit is correct and that's good. If it falls outside, it's either too big or too small. Now, for some reason, that's not good enough for you, or if those lines aren't there, you can go ahead and measure. And you simply want to measure the midpoint of the upper arm. That's where you're going to get your circumference, because remember, circumference is going to change based on where we are in the arm. So you will measure from the acromion to the olecranon process to find the midpoint. And then at that midpoint, we're going to take a tape measure, wrap it around, and get our circumference. And conveniently, all blood pressure cuffs should have this range in centimeters printed so you can match it up. So on the picture below, I've highlighted 25.4 to 40.6 centimeters. And again, worst case scenario, if all of this documentation on the cuff is for some reason scratched off or not there, there's a really quick rule you can go by, which is the cuff bladder length. Keep in mind the cuff bladder is not the whole cuff. It's only the portion of the cuff that inflates. So the cuff bladder length should be roughly 80% of the arm circumference. You can use that rule if you like it. If not, that's fine. Okay, moving on. The position of the cuff should be roughly 1 inch above the crease of the elbow. You can see that nicely demonstrated in that picture here. If you take a look at his sleeve, it's all the way up. Clothing should not be underneath the cuff. Next, you want to palpate the brachial artery, which on the crease of the elbow is always going to be slightly medial or to the middle. So go ahead and palpate the brachial artery. And the reason we do that is to properly place the cuff. And typically there will be an artery mark on the cuff, which will either say artery mark, or it's typically denoted as a circle with a line through it, like in the picture. Again, worst case scenario if this documentation is not on the cuff or if it's rubbed off for some reason, a good rule of thumb is that the flexible tubing of the measuring device should line up with the artery. Next, you want to tighten the cuff and Velcro it such that it's snug, but it still allows for about 2 fingers to slip underneath it, 2 finger width. So tight, but not too tight. All right, this next step is one of those steps that we all learned when we were initially being taught how to do this, but tend to leave out because it's a little more time consuming and maybe we don't even really understand why we need to do it. And that's estimating systolic blood pressure prior to even taking blood pressure. So we do this by palpating the radial artery, which is on the wrist, the artery we use to get pulse. You're then going to rapidly inflate the cuff to about 80, and then keep increasing that pressure by 10. And what you want to do is you note the pressure at which that pulse goes away, at which you can no longer feel the pulse of the radial artery. That pressure that you notice is called the pulse obliteration pressure. And this is our approximate systolic blood pressure. And why are we doing this? Well, it's critical in avoiding errors due to a phenomenon called the oscillatory gap. And I'll get to more of this later. You may have already heard of this, but I'm going to detail really why this is important and what's so scary about making an error due to this. Okay, next, we're going to be placing the bell of our stethoscope over the brachial artery just below the cuff. So our cuff is fitted. We're going to put our stethoscope in place. And it's important to use the bell. It's not necessary, but most of the times you see people doing this, or you Google pictures of it, you see the picture in the bottom right-hand corner, which is actually wrong. They're using the diaphragm. The diaphragm's better for picking up higher frequency sounds, crackles in the lungs. The bell is really good at just isolating low frequency sounds, which that's what we're looking to pick up. So try to use the bell. And I also see people trying to slide the diaphragm kind of underneath the cuff, and that's really not necessary. Okay, our bell is in place. Now it's time to actually take the blood pressure. So we're going to rapidly inflate our cuff to about 20 to 30 millimeters mercury above that estimated systolic pressure or our obliteration pressure. Then you're going to open that adjustable valve, starting to release air at a moderate rate, roughly 2 millimeters mercury per second, if you're keeping track. And you're going to listen for in the stethoscope and note the very first carot cough sound you hear. This is your systolic pressure. Really briefly, let's talk about what carot cough sounds are and why they exist. They sound like a loud tapping noise. I can play this audio here. I hope it works for you. Okay, I think that's enough of that. I hope you were able to hear the audio. And one thing you might note is that the actual character of the sound changes. So in reality, there's actually documented 4 different phases of carot cough sound. And really what that does is kind of advises you of where you are in measuring blood pressure. I think it's a little beyond the scope of this talk, so I am not really going to be talking about it. But let's talk about what makes these sounds briefly. So really an open tube or a blood vessel with fluid flowing through it moves in a laminar flow. So if you look at the picture to the bottom left-hand side, you see those lines there. They're kind of stacked on top of each other like sheep, and they're flowing cleanly and smoothly through the pipe or blood vessel. And this is called laminar flow, so it's not turbulent. And what's important is it is silent. You don't hear it when you put your stethoscope on an artery that is completely open. When the cuff is fully inflated, though, the vessel is completely closed. It's in a no-flow state, so that's our right-hand image, the upper pane. And that's also going to be silent because, again, no flow. But as we begin to reduce cuff pressure, that vessel starts to open, but kind of in a deformed state. So look at the left picture, the bottom pane, and it shows an obstruction that kind of constricts the blood vessel. So now our laminar flow is disrupted and we get turbulent flow. And that turbulent is what we hear. It makes sound. Those are the carotid cough sounds. Okay, moving on. So we heard our first carotid cough sound, loud tapping, and we're continuing to deflate the cuff. We noted that systolic pressure. Next, you want to note the pressure at which those carotid cough sounds become absent. This is your diastolic blood pressure. And then just to be safe, continue deflating the cuff for an additional maybe 10 millimeters of mercury or so, just to be sure. Okay, if the blood pressure is elevated, you're going to need to take another measurement, but you need to make sure you wait at least 1 minute in between measurements. And be sure to note which arm you used, be sure to note the cuff size you used, and be sure to note the position of the patient, because there may be times that necessitate you take a pressure on someone who's laying down or possibly in a wheelchair who's not quite in the adequate position. Also noting which arm you use is very important because, as you may know, the heart is a little bit closer to the left arm, so that pressure is going to be a little bit higher. And so we want to be consistent. We always want to take the pressure in the same arm. So pick one and go with it. Another issue that's been brought up is the issue of the automaticity of your electronic medical records. Now, some of your EMRs may auto-input your very first blood pressure. They may actually just read it right off the machine if you're that fancy. But you need to make sure that all data is documented. So if one is elevated and you need to take another, you need to make sure that makes it into the documentation as well. That may require some manual entry. And then again, if you do ever see a blood pressure of 180 or 120 diastolic, you need to contact somebody. This is an emergency. It needs to be taken care of urgently. Next, let's talk about some issues that introduce error into our measurements. Kind of already touched on this, but this is the white coat effect. Surprisingly, roughly 15% of your patients are going to experience this phenomenon. And this can raise blood pressure by roughly 20 millimeters of mercury, which is quite a bit. What's interesting about this phenomenon is it's not necessarily associated with anxiety. You can't necessarily ask a patient, you know, am I making you anxious, and figure this out. And this is why home measurement is really pretty key when taking care of our hypertensive patients or tracking our pre-hypertensive patients. Next, cuff size. We already touched on that really briefly, though. An arm circumference of greater than or equal to 40 centimeters is too large for any cuff to measure blood pressure accurately. That's when you need to use a thigh cuff. And that's a little beyond the scope of this lecture as well, but just know that that option is there for you. Next, the dangling arm can falsely elevate blood pressure by 22 diastolic or 22 systolic or 19 diastolic. And that has to do with positioning, which we've already covered. But that arm that's dangling lower than the heart is going to artificially raise blood pressure simply due to gravity alone. Next, that oscillatory gap, which I mentioned briefly and want to discuss a little bit more now. So, definition. The oscillatory gap is a loss of carotid cough sounds before diastolic pressure is reached. So I'm really, maybe just for the sake of your entertainment, going to try to make these sounds myself. But I'm going to make the sound of a normal patient, and then I'll try to show you what an oscillatory gap might sound. So the cuff's inflated, we're deflating the cuff, and here's a normal patient. So we very clearly heard our systolic or our first carotid cough sounds, and we heard the end of them, which would be diastolic blood pressure. But here's my best interpretation of a oscillatory gap. So cuff's inflated, we're deflating, here we go. So if I did a good enough job, you're going to notice that first carotid cough sound, same thing, but it actually goes away and then reemerges, and then we hit diastole. So this phenomenon is common in elderly patients. What it does is it causes us to underestimate systolic blood pressure and overestimate diastolic blood pressure. There's no accepted real mechanism as to why this happens. There's still a lot of theories out there, and I believe the leading theories have something to do with stiffness of arteries. They get stiffer and less compliant as we age. And I wanted to give you a really quick demonstration as to why this is important and how this can hurt people if we're not estimating that systolic blood pressure first. So I've got a little diagram thingy I made here in the center of your screen. It's really only a y-axis, and that's just representing pressure in millimeters of mercury. So 90 at the bottom, 140 at the middle, 180 at the top. And then you'll see this kind of upside down, stretched out bell curve thing that's shaded in orange. And that's representing where in that pressure we're hearing carotid cough sound. So it looks like they start at 180 and end at 190. So let's say, just for the sake of argument, that we skip that step in a normal patient of estimating their systolic blood pressure, and we inflate the cuff to 145. Well, at 140, as you can see on the little image here, you already hear carotid cough sound, so you know you're in trouble, and you inflate the cuff further because you heard sound. So you inflate it to maybe 185, deflate it, and you get your reading of 180 over 90, which is an emergency, and you potentially save this person. Now contrast that to somebody with an oscillatory gap, so that's on the right. I want you to note two things. That one, the blood pressure is the same, so systolic carotid cough sounds start at 180, end at 90, and then the difference is that they're absent somewhere in between, I don't know, say 160 and 140. So say we skip that step of estimating systolic blood pressure again, and we inflate our cuff to 145. We're in the gap right now, and we're not hearing any carotid cough sounds, so we think we're okay. So we deflate the cuff, we reach 90 diastolic blood pressure, and we get a reading of 140 over 90, and we miss a possible impending stroke. We send this person home. That's a big deal, and that is why we estimate our systolic blood pressure. If we would have taken that initial obliteration pressure, we would have known that their systolic is somewhere around 180, and we would have possibly saved this person. Okay, so we talked about the white coat effect, we talked about cuff size, dangling arm, oscillatory gap. Next is bias, and for some reason, most people like nice even numbers like 120, 90, and 80. So even though the needle on the manometer is telling us one thing, we kind of want to just bump that measurement a skosh to make it nice and clean and easy to record. So we really need to focus in on the manometer and record exactly what we're seeing. And then finally, the modifying factors which we talked about, like coffee, running late for an appointment, and even pain elevates blood pressure. Next, I want to talk about home monitoring and why is this so important. A lot of patients are going to ask you about this, and I thought this might be helpful to run through. So one of the important reasons we encourage patients to do this is to track their own blood pressure in a familiar setting. So rather than have our single data points in time every year or every 2 years, we can get data points, weekly and compare those readings to what we're getting in the clinic. So then we can pick up things like spikes here and there in blood pressures, or maybe a white coat effect, things like that. It's helpful in tracking treatment and effectiveness of medications, especially when they're keeping a journal of their blood pressures. It's very helpful in alerting a doctor to potential complications. If a patient notices they are in hypertensive urgency, they can notify their doctor. If someone's kind of hanging around that pre-hypertensive state, this can really help to provide patients with earlier diagnosis and earlier initiation of treatment. And also, it just generally encourages better control. In the same way that a Fitbit or just any kind of like pedometer or exercise device encourages more exercise, people actually keeping track of their own data encourages better control, whether that be compliance with medications, exercise, and diet. And finally, it's possible that it can cut costs by decreasing visits. So if somebody's doing really, really well with their validated device, they may not have to come in as often. Next, let's talk about devices in general. The first thing we want to do is really encourage our patients to check and see if their insurance providers cover this cost. Some insurance providers cover the cost of pedometers like a Fitbit because it's going to save them money in the long run. So we want to check on this first. Next, automatic electronic devices are preferred because it's just going to take care of everything for the patient. I don't think anybody would advise a patient doing it manually with their own mercury unit. If some of these devices are too costly, public devices are widely available in most pharmacies like CVS, Walgreens, even in Walmart. What's really important to note and communicate to your patient is these devices need to be validated when they get them new, and they need to be validated every year. And you do this with them in your office, and you're simply comparing measurements that they're getting to measurements that you're getting on your device. And upper arm cuffs are preferred, but if the patient's arm is too large, wrist devices are also available if needed. And just really briefly on the wrist cuffs, which are kind of a new device, they really only need to be used if absolutely necessary. So if a patient's arm is much too large, or maybe they have a fistula in place for dialysis, or maybe there's too much pain involved, then it can be okay to use one of these. But the problem with them is they're only accurate, and they can be accurate, but they're only accurate if used exactly as directed. And the problem with these is they're much easier to misuse. There's a lot more steps, and they're a lot more finicky than the good old upper arm cuffs. What they tend to do is overestimate blood pressure and just generally be less accurate overall over time. And again, like any other device, they really need to be validated with you, the healthcare provider. So speaking of validating these devices, it's kind of up to us as well to educate the patient. And so one of the things we want to do is, again, encourage them to bring their new device in and validate it against your office readings. And this is also a great opportunity to simply watch the patient put on and use their device and ensure they're using it properly. You know, if they have a wrist device, are they holding their wrist up to their heart like they should? And then obviously we want to cover proper techniques, including positioning. There's modifying factors like coffee, alcohol. You need to avoid those 30 minutes before, and clearly cuff fit. And that kind of brings us to the end of today's webinar. I put up these 3 patient resources. For all of these, I apologize for the long URL, but my advice would be to use your camera phone and just snap a picture if you can of the screen. But the AHA has a nice jumping off page for patients with hypertension. Mayo Clinic has a great little article on home monitoring for patients, and WebMD has similar resources. Provider resources include one from Medline Plus on measurement for us, the healthcare provider. There's a nice toolkit from the American Medical Group Foundation. It's just a collection of articles that are nice short PDFs, short reads. And then obviously the JNC 8 guidelines are always good to keep up on, even though I didn't cover those in this webinar. Here are my citations. And then just really quick, this is what we went through: background information, including definitions, risk factors, screening, and then measurement. So we talked about our tools, position, cuff fit, procedure, correct cough sounds and what they are, errors, and home monitoring. So this is where I leave it to you to ask any questions you may have. Please type them in the box, and I'll wait a minute.
Thanks, Mike. Okay, so I see that we have a couple of questions. Again, as a reminder, if you have a question, please type it in the question box located on the webinar screen. And I'll go ahead and read the first question. It's often difficult to lose weight. What do I tell patients who are frustrated about the difficulties in losing weight?
That's a great question, and clearly weight impacts blood pressure, and that's one of the things we want to emphasize. I think people tend to get discouraged because they begin exercising and or eating properly, and they don't see gains immediately. And typically that's for a couple of reasons. One may be that often in the first couple of weeks you're losing water weight. Another reason is if you're doing somewhat intense physical activity, you're gaining muscle. So you may not actually be seeing the actual amount of fat you may be losing. But what's really most important, I think, about this process with patients is that they're not just exercising to lose weight or to become lighter. They're exercising to become healthier. It's better for their blood vessels. It's better for their blood pressure. It's better for their brain. It's better for their kidneys. So even though they may not be making immediate gains, I think it's always, always very important to stress that this is for your health. This is not always for how you look in the mirror, although that's a nice side effect. I hope I answered that adequately.
Great. Let's see. Next question. For some patients, it's hard to understand the significance of controlling their blood pressure. They don't feel bad or sick on a day-to-day basis. So how do you stress the importance of controlling a patient's blood pressure?
Sure. I think it's really up to us as healthcare providers to educate our patients, just kind of in general. And this is one of those tough ones where the disease is insidious. It's an insidious process. So you consider it like an early cancer that's spreading in the body, and you don't notice it until it's too late and it's metastasized everywhere. And again, I think I mentioned it earlier, hearing people say things like, Grandma June died of a stroke, or Uncle Art died of a heart attack. I think, those are opportunities to stress with people, and that really the underlying cause is high blood pressure in many of those cases. And it's really an insight into how the public views high blood pressure. So it's not that we need to be using scare tactics, but it's to communicate that we're worried about high blood pressure because it is a silent killer, because you can't feel it, although there is a perception amongst people that you might get a headache or so on and so forth. That's not true all the time. And that it's a chronic disease that leads to, problems like MI or stroke. And then I also think it's important to emphasize with some people that things like stroke and MI, they take you out pretty quickly, and some people are maybe okay with that. But there's also a morbidity associated with going into kidney failure. So going on dialysis is not a pleasant experience. Having erectile dysfunction is not a pleasant experience. Losing your vision is not a pleasant experience. So we can also talk about morbidity as well as mortality.
Okay, we have another question. 1 second. Okay, Mike, the next question is, would you be okay with sharing your slides to be available to help health centers with educating their staff on the proper blood pressure device application techniques, such as reasons for the erroneous results?
Absolutely, absolutely. These slides are for all of you.
Okay, this has been great. Well, thank you, Mike. Again, looks like that's all the questions for today. I would like to take a moment again to thank Mike for conducting this presentation today. We will post the recordings of each learning session to the LPCA website, and we will also obtain a copy to forward via email of webinar 3. And this concludes our Learning Series webinar. Thank you for participating. Have a great